Hello everyone. We will be starting with the basics of periodontics. So that is the periodontium. As we know, periodontium is composed of gingiva, periodontal ligament, cementum and bone. So today we are starting off with gingiva. Now this topic will be covered in 4 parts. In today's session, we will be talking about the macroscopic and microscopic anatomy of gingiva. Before we begin, don't forget to press the subscribe icon. Now our body is protected by a continuous surface lining. Right from the skin to the gastrointestinal mucosa, these linings protect the structures underneath them. But when teeth erupt in the oral cavity, this lining is disrupted. Rather, the continuity of the lining is disrupted. So it's only the exfoliation or extraction of teeth which will restore this lining. This is the reason that the tissues which are present around the teeth are designed in such a way that they provide a perfect seal around the tooth via junctional epithelium and epithelial attachment. They should be able to withstand the forces of mastication and also defend the space between the tooth and the soft tissues against microorganisms. Normal gingiva covers alveolar bone and tooth root to a level just coronal to the CEJ. Topographically, it is divided into the marginal gingiva, gingival sulcus, attached gingiva and interdental gingiva. Now first we will talk about the marginal gingiva. This portion is the marginal gingiva. It is also called as the unattached gingiva. Now it is the terminal edge of the gingiva that surrounds the teeth in a collar-like fashion. Now in around 50% cases, there is a shallow depression which separates the marginal gingiva from the attached gingiva. This depression is called as the free gingival groove. Now the marginal gingiva forms the soft tissue wall of the gingival sulcus. It can be separated from the tooth with a periodontal probe. So you insert the periodontal probe over here. Now the most apical portion of the marginal gingival scallop is what is called as the gingival zenith. Coming to gingival sulcus. A gingival sulcus is a V-shaped crevice. This portion is the gingival sulcus. On one side, it is lined by the margin of the gingiva, and on the other side, we have the tooth. Now, the depth of the gingival sulcus is an important diagnostic parameter. So, in case of germ-free animals, this depth is around 0 mm. But this is possible only in experimental conditions. The normal probing depth is 2 to 3 mm. When the gingival sulcus is pathologically deepened, it is called as a periodontal pocket. Now there are two more terms that we need to understand. There is something called as pristine gingiva and there is something called as clinically healthy gingiva. A pristine gingiva is a normal gingiva which is free from any amount of inflammation. Whereas in case of clinically healthy gingiva, there are certain inflammatory cells which are present. Like we have neutrophils which is associated with the junctional epithelium and lymphocytes which are present in the subjacent connective tissue. But when you look at it clinically, this clinically healthy gingiva resembles pristine gingiva. It's only under the pathologic section where you can make out the difference between the two. Attached gingiva is continuous with the marginal gingiva. It is firm and resilient and bound to the underlying periosteum. Facially, it is demarcated from the movable alveolar mucosa by the mucogingival junction. So we know that the marginal gingiva is separated from the attached gingiva by the free gingival groove, whereas the attached gingiva is separated from the alveolar mucosa by the mucogingival junction. Now, the width of attached gingiva is an important clinical parameter. Now, this is the distance from the mucogingival junction to the projection on the external surface of the bottom of the gingival sulcus or periodontal pocket. Periodontal pocket, as we saw, is a pathologically deepened gingival sulcus. Now, this width is maximum in the incisor area. So, in case of maxillary incisors, it is 3.5 to 4.5 mm. In case of mandibular incisors, it is 3.3 to 3.9 mm. It is the least in the first premolar area. So, in maxillary first premolar, it is 1.9 mm. In mandibular first premolar area, it is 1.8 mm. Now, we have something also known as the width of keratinized gingiva. When you say width of keratinized gingiva, it includes the width of the marginal gingiva plus the width of the attached gingiva. Another factor to be considered in case of attached gingiva is the adequacy of the width of attached gingiva. It can be adequate width, a particular width, or it can be inadequate. Now, how do you decide whether the width is adequate or not? There is a simple test for this. What you need to do is you need to stretch the lips and the cheeks. If you notice any movement of the marginal gingiva, that is when you can say that the width of attached gingiva is inadequate. So, why do we need adequate width? Adequate width is required for protecting the periodontium from injury caused by masticatory forces. Then it should allow for easy placement of the brush and avoid brushing the mucosa. Now imagine this width of attached gingiva is less. So there is going to be difficulty when you place your brush over here while brushing. You might harm the mucosa. So this will again hamper your oral hygiene. So adequate width, it enhances plaque removal along the gingival margin and improves aesthetics. So always check for the adequacy of attached gingiva in case of apartments planned for FPDs, areas related to denture or areas where implants are to be placed. Now how much should the width of attached gingiva be for you to call it adequate? There is no standard number which has been assigned for this. The amount of gingiva which is sufficient to prevent recession in the opinion of individual practitioner is what is called as adequate width of attached gingiva. Now, how do you differentiate between the attached gingiva and alveolar mucosa? So, we are going to be considering it under three headings: functionally, anatomically and histochemically. Functionally, check for the movement. There will be some movement occurring in case of the alveolar mucosa and there won't be any movement in case of the attached gingiva. Anatomically, if you check the color difference, attached gingiva will be light pink in color, whereas alveolar mucosa is dark red. There is a large amount of vascularity in the alveolar mucosa. Surface characteristics when you consider stippling. So, attached gingiva will show the presence of stippling. What is stippling? We'll see in the further videos. Whereas in case of alveolar mucosa, there won't be any stippling present. Next test is the histochemical test, wherein there is this solution called as Schiller's iodine solution. This solution is applied and it reveals the glycogen content which is present in the epithelium of the mucosa. Alveolar mucosa contains glycogen, so it takes up the stain, whereas attached gingiva will not take up the stain. Then there is also something called as gingival thickness. Now gingival thickness, it ranges between 0.5 to 2. So we saw about the marginal gingiva and the attached gingiva. Now we come to the interdental gingiva. So as the name suggests, it is present interdental, so it is present between the teeth. It occupies the gingival embrasure or the space which is present beneath the area of contact. So when you check from the lateral view, what we see is a valley-shaped depression. So it will connect the labial and the lingual papillae. This valley-shaped depression is called as caul. So it represents the fusion of interproximal junctional epithelia of two adjacent teeth. It's like a concave bridge. Now this is the site of initiation of pathological breakdown. Normally interdental gingiva is pyramidal shape. Okay. Now if in case there is a diastema present, like in such case, then the gingiva is bound to the interdental bone. So you do not have any interdental papilla here. Now the shape of the interdental papilla depends on four things. First, it depends on the contact relationship between the teeth. Now if you see these two teeth there is a contact point. So you are going to see a pyramidal shaped papilla. Here there is no contact. It's a diastema present, so here the papilla becomes flattened. Then it also depends upon the width of the aproximal tooth surfaces. Then it depends upon the course of the CEJ and the presence or absence of some degree of recession. Okay, so first we have the contact relation between adjacent teeth, width of the interdental or the proximal tooth surfaces, the course of the CEJ and the presence or absence of some amount of recession. So now we come up to the microscopic anatomy of gingiva. Microscopically, gingiva is divided into three areas. This whole thing is the outer epithelium, which includes the marginal gingiva as well as the attached gingiva. On this portion, what we call the sulcular lining, the sulcus lining is the sulcular epithelium, and this portion is the junctional epithelium. We will have a look at it one by one. Coming to the outer epithelium, also known as the oral epithelium. Now it covers the crest, so it covers the outer surface of the marginal gingiva and the attached gingiva. It's around 0.2 to 0.3 mm thick. Now it can be either orthokeratinized or parakeratinized. This we will be looking up in the next video. Now it has four layers. We have the stratum basale or the basal layer, stratum spinosum or the prickle layer, stratum granulosum, which is the granular layer, and stratum corneum, which is the conified layer. The degree of keratinization increases with age. The keratinization is maximum in the gingiva, followed by the ventral surface of the tongue, and lastly the least in the cheek. Coming to the keratins that are present. What we can see here, okay, coming to see the keratins. So, in case of orthokeratinized, what we see is K1, K2, K10 and K12. These are specific to the epidermal type differentiation. In case of orthokeratinized, it's expressed more as compared to the parakeratinized. Then in case of highly proliferative epithelia, we see more of K6, K16. In parakeratinized, we see K19. Now this K19 is absent in orthokeratinized. And then we have some stratification specific keratins, that is K5 and K14. Coming to the histoenzyme reactions, we have to talk about acid phosphate and we talk about the pentose enzyme, shunt enzyme. So acid phosphate, in case of outer epithelium, it is positive, as well as the pentose shunt enzymes show a positive reaction. Next is the sulcular epithelium. Okay, this one. So this, it lines the sulcus. It is thin and non-keratinized stratified squamous epithelium. It extends from the tip of the junctional epithelium to the crest of the marginal gingiva. Now we know that this is non-keratinized, so it is more susceptible to attack. Okay. Now it can keratinized. It can keratinize. Why or when? In two conditions. One, if it is reflected and exposed to the oral environment, or if the bacterial flora from the sulcus are completely eliminated. Similarly, now we saw oral epithelium or outer epithelium is keratinized, right? But this can become non-keratinized if it is in place in contact with the tooth. Now this circular epithelium, it shows the presence of K19 and K4 and K13, which are the esophageal type of cytokeratins. Now this circular epithelium, it acts like a semi-permeable membrane. So the injurious bacterial products, they pass through the gingiva and into the tissue fluid. It does not show the presence of any neutrophils. Next we have the junctional epithelium. Okay, this portion, if you take here, it is something like this. So one side we have the tooth, this side is the gingiva, okay, the gingival connective tissue, and this portion, what we see, is the junctional epithelium. So this is non-keratinized stratified squamous epithelium. It tapers from the coronal to the apical. So on top you will see around 10 to 29 cells. At the tip you will see around 1 to 2 cells. It is around 3 to 4 layers thick and number of layers increase with age. Now it has two strata. Okay, that is the basal and suprabasal. Basal layer is the one which faces the connective tissue. So this is the basal layer. Whereas this one which faces the tooth is the suprabasal layer. Length is 0.25 to 1.35 mm. The formation of junctional epithelium occurs during tooth eruption by a confluence of outer epithelium and reduced enamel epithelium. They together form the junctional epithelium. Now coming to the keratins which are present, it shows the presence of K19, then it has K5, K14. These two are the stratification specific. It shows K8 and K18. Now as we saw earlier, K6, K16, these are keratins which are present in highly proliferative epithelia. So we would expect them to be present in the junctional epithelium, but that is not the case. Even though the turnover is very high, K6, K16 are not present in junctional epithelium, and it is the only non-keratinized stratified epithelium which is present in the oral cavity, which also does not synthesize K4 and K13. K4, K13, this is synthesized by the other non-keratinized epithelium which is present in the oral cavity, that is the circular epithelium, but it is not synthesized by the junctional epithelium. Now the junctional epithelium is attached to the tooth by internal basal lamina, and it is attached to the gingiva by external basal lamina. Now this internal basal lamina has again two parts. We have the lamina densa and the lamina lucida. Lamina densa is adjacent to enamel, whereas lamina lucida shows the presence of hemidesmosomes. Now these hemidesmosomes, they regulate gene expression, cell proliferation and differentiation. Junctional epithelium plus gingival fibers is what is called as the dentogingival unit. Now why are junctional epithelium so important? The junctional epithelium is firmly attached to the tooth surface, so it forms a barrier to prevent the bacteria from colonizing the subgingival surface. It allows access to the GCF and the immune cells, and it shows a very high turnover which contributes to rapid repair. The turnover rate is different in different areas. Like in case of the palate, tongue and the cheek, the turnover is 5 to 6 days. In case of gingiva, it is 10 to 12 days. And in case of junctional epithelium, it is 1 to 6 days. If you have been watching the video properly, comment in the below section the answer of the following question. Which part of the gingiva is the site of initiation of periodontal disease? In the next video, we will be talking about the process of keratinization. If you have any doubts, put them in the comment section. I will try to clear them in the subsequent videos. Thank you for watching.